going to talk about the diagnosis and management of blood cancers. In general, we use different approaches for the different blood cancers. Traditionally, we look into, as part of the diagnostic management, we rely on biopsies of either lymph nodes or other organs that are compromised to make a proper diagnosis. So the morphology of the disease is very important for us because it's going to tell us whether we're facing a case of acute leukemia, chronic leukemia, or other conditions such as lymphomas or multiple myeloma and so forth. And usually we also rely on, as a second part of the diagnostic sort of approach, to do some imaging studies. And in this case, we relied on the need for a PET-CT scan, which is going to inform us as to whether there are some abnormal tissues, but also whether those tissues are suspicious for cancer or not. Traditionally, also we rely on lab work, and we usually check on values of hemoglobin, platelets, and white cells, and other inflammatory markers that are going to tell us whether a lymphoma or acute leukemia or other conditions that the one that we discussed are present or not. Regularly, also we use other more advanced information to classify and stratify these conditions, and we rely on the cytogenetic studies, basically looking into the genetic makeup of the patient, and also molecular studies looking into the presence of certain mutations that may contribute to the development of any of the blood cancers that we talk or refer about. So then after we rely on the morphology, the diagnostic testing in terms of imaging studies and cytogenetics or genetics, and then mutation studies, we look into we're trying to stratify patients into either low risk, intermediate risk, or high risk. Of course, that depends on the sort of blood cancer that we're talking about. Let's concentrate a bit for the next couple of minutes on acute leukemias, for instance. In the setting of acute leukemias, we usually do blood work followed by a bone marrow biopsy. In certain occasions, we do PET-CT scans or other scans to see whether there is some disease outside of the bone marrow. And then usually we rely on the genetic markers and mutation studies to see whether a patient belongs to the high risk, intermediate, or low risk category. Of course, each risk category has its own approach. And in the case of leukemias, for instance, whenever we're facing a patient who has or who is in the intermediate risk category or high risk category, we prepare patients and we start discussions for a potential allogeneic or donor bone marrow transplant. In the setting of what we call a low risk acute leukemias, usually patients get treated with chemotherapy, followed by consolidation or more chemotherapy. And again, the intent for all these blood cancers is to cure patients. So that's what is really important to talk about these conditions. When we talk about lymphomas, and in the case of lymphomas, we rely on the same blood work, imaging studies, and genetics and molecular studies. And we'll also look into other factors such as age of the patient, such as where the disease is in terms of whether it's in different parts of the body, only one part of the body. And we're relying on all those different factors to stratify patients based upon scores. And the scores that we use is called, the main one for all of these conditions, is called the International Prognostic Index, that allows us to classify patients into the low risk, intermediate, or high risk, and as such have an idea of, in terms of the prognosis of these patients. When we talk about multiple myeloma, we do the same sort of studies, blood work, imaging studies, bone marrow biopsy. But the bone marrow biopsy is very important for us because it gives us the information as to whether the patient has what we call a high risk multiple myeloma or has a standard risk or a low risk multiple myeloma. The importance of this relies on the fact that for patients who are high risk multiple myeloma, or usually for all these kind of risk categories, usually bone marrow transplantation meaning for their own patients, for the same patient, meaning autologous bone marrow transplantation, it's been shown and proved that helps in terms of long-term survival and long-term without the disease. When we talk about other conditions such as myelodysplastic syndrome, we do the same blood work, followed by imaging studies when needed, and then also followed by bone marrow biopsies. That is going to give us an idea as to the genetic markers and molecular alterations that are needed for this condition. In the majority of cases, these patients are going to need a sort of a donor or allogeneic bone marrow transplantation. Usually, the patients who fall into the high risk category are the ones that are going to need that kind of intervention. While, on the other hand, patients who are low risk, they usually need some sort of therapies or chemotherapies to continue or to get the disease under good control. When we talk about myelofibrosis, which is another bone marrow disease, we're talking about patients who have some issues in producing some of the cells, white cells, red cells, and platelets. Whenever we talk about these patients, usually we also do the same algorithms and looking into blood work, imaging studies, and a bone marrow biopsy, looking into the alterations in the genetic makeup and mutation analysis or mutation studies. And trying to classify these patients into what we call the low risk or the high risk or intermediate risk. Usually the patients who belong into the intermediate risk category, type 2, and high risk are usually the patients who are eligible for bone marrow transplantations, donor bone marrow transplantation, or what we call allogeneic bone marrow transplantation. When we talk about other sort of conditions, and we briefly touch base about lymphomas, in the majority of cases, B-cell lymphomas, we usually treat with chemotherapy and induction therapy, but we do this sort of diagnostics, the same ones, and we stratify these patients in what we call indolent lymphomas versus aggressive lymphomas. And when we talk about the indolent lymphomas, it's very good to know whether it's indolent or aggressive, simply because in the case of indolent lymphomas, we don't cure these patients, but hardly ever we need to start some kind of therapy in these patients. In other words, in some cases, in many cases, I should say, for indolent lymphomas, we just kind of follow patients and treat accordingly based upon certain diagnostic criteria and treatment criteria. In the case of aggressive lymphomas, we need to treat all these patients, but the intent to treat these patients, of course, as I said, for all blood cancers, is to cure these patients. When we talk about this sort of diagnostics, again, we rely heavily on blood work, imaging studies, and also bone marrow biopsies and other biopsies as needed to look for cytogenetics and molecular studies.